In the field of medicine, pain management has emerged as one of the fastest growing specialties in the last 10 to 12 years. There are just so many people here in this country who suffer from pain in one part of their body or another and have been unable to find relief. Now, there are many doctors of differing backgrounds who have attempted to help these people. However, there is one group of doctors who are uniquely qualified to treat these kinds of patients. They are anesthesiologists with specialized training in interventional pain management, such as the doctors here at Connecticut Pain Care, which is headquartered in Danbury with other offices throughout the state. Founded some 12 years ago, this unique medical practice is one of the largest of its kind in the state and offers an extensive menu of unique treatments, and they are experiencing a very high success rate. To learn more about this unique pain management practice, we visited with the three board-certified doctors who are partners here. The president and medical director is Dr. David Clark.
Pain is the most common reason people go to visit a doctor. And the most common complaint will be headaches, followed by back pain. And back pain by far is the biggest problem for people on a daily basis to do their normal activities of daily living, what we refer to as ADLs. And that is huge bearing on not just people who are just your average person, but also obviously workers who are injured on the job. And the biggest cost of the workers' compensation system are back injuries and the long-term care of those back injuries. Our goal usually is to limit the amount of medication and get the pain to go away so you don't need to take medication.
Pain management is a specialty that has really come into its own. People were doing very rudimentary, simple cases. But with the advent of technology, the specialty has grown dramatically. And the types of interventional work that you can do to really make an impact on people's lives has progressed dramatically, as I could see technology enabling me to make an even greater impact in people's lives.
The point is that chronic pain over the years has been very poorly understood and has been treated even more poorly. The fact is that most of the chronic pain as we know it today is treatable. It's no different than, say, diabetes or hypertension. Some of the chronic pain may not be curable, but it's absolutely treatable. And we have, especially with the nature of the practice that we do, it's not just medical management, it's interventional pain management. We have the modalities available wherein we can block or modulate or change the perception of the pain in the body.
What we're doing here is an epidural steroid injection at the lowest disc level in the spine to try and treat both back and some leg pain for this patient. Getting the skin nice and numb. And now I'm going to be placing a needle down into what we call the epidural space. And I'm doing this under X-ray guidance for both accuracy and safety of the procedure. And we look at this X-ray under two different views, one looking from the top and one looking from the side. So two-dimensionally I can see that the needle is in the correct place. And just go nice and slow during this part to be really careful. I'm now shooting some dye, which helps me outline that I'm in the right area. I then drop some medications. This is a combination of some local anesthetic and steroid, as well as some saline to increase the volume. And then I just inject out. It's a lot of pressure as the medicine goes in. And I just make sure my X-ray shows the medicine went in the right place, and that's it, we're done. The laser device contains 4 different components. It contains the ability to take video inside the patient. It contains a fluid port, a light source, and the actual laser bundle. This allows me to remove pieces of disc material using the laser under direct vision. I'm allowed to see directly inside the disc. This particular technique is utilized by very few physicians in this country. Given my experience utilizing multiple different modalities of treatment, either the laser allows me to remove a little bit larger amount of disc material and allow me to decompress slightly larger disc herniations. I have found better results with this modality. What I'm doing now is inserting a needle into the disc. Through this needle, I'm going to pass a coil around the disc. This is what the coil looks like. I will be passing this coil on the circumference of the disc along the back surface of the disc, enabling me to heat the back wall or outer wall of the disc. There are nerve endings that occur in the disc that this will denervate or prevent from allowing nerve transmission. The other component that this does is by heating the outer wall of the disc, it allows the disc to remodel and seal the tears in the outer wall of the disc, hopefully preventing reherniation and also simultaneously treating the patient's back pain.
Dr. Cloth made a huge difference in my life. He took a look at my MRIs that other specialists had looked at, and he saw things that I don't think other people saw, and he laid out a course based on my situation, which led me to have this IDET procedure. At the end of October of 2002, I had the procedure, and the two lowest discs in my back, they heated up the center of the disc, and I believe they just kind of took out a little bit of the center of the disc and basically decompressed the discs. Well, I have no marks on my back right now. I run competitively, I play golf regularly, and now I'm working full-time. And I haven't missed any days of work in 4 years. He's really changed my life.
The new technologies that really began, that started to evolve and have improved over time are things like radiofrequency ablation, spinal cord stimulation, intrathecal pump placement. Each one of these types of devices is used to treat and deal with a different type of pain. From simple, literally, destruction of a sensory nerve so that your brain can't perceive pain, which is radiofrequency ablation, all the way through spinal cord stimulation, which is putting leads, electrodes on a person's spinal cord to override the pain signals that are reaching the brain. Intrathecal placement of narcotics is another method of treating pain. All of these things have really been around since the early 1990s, but over the course of the past 15 years, they've improved dramatically.
I remember going home, sitting on the couch, and I was kind of like waiting to feel some pain, and I didn't. And it was the first time in like 10 years that I realized, it dawned on me that this is how normal people feel. They don't have pain.
This is a spinal cord stimulating device, which primarily consists of two components. One is the electrical lead, which is placed on the spinal cord or on the nerve roots to block the pain. And then, of course, this needs an energy source to stimulate it. And the energy source is the implantable pulse generator, which is implanted in the body. So the patient does have control. He can switch it on or off. And we have access to different parameters. We can use different pulse widths. We can use different level of amplitude and different frequencies to the level that they are most effective in blocking the pain in a particular patient. So this is the generator. These are the leads which are implanted in the patient.
I was diagnosed with peripheral neuropathy 11 years ago, and my neurologist at Yale sent me to Dr. Sood. I was on pain medication for a long time and various other drugs to try to deal with the pain from the neuropathy. And in May of 2000, he put the first stimulator in. Within 3 months, I was off all my pain medications and used just the stimulator. I had to wear a brace for 6 weeks to hold the leads in place. And then after that, I've had no physical therapy. I do elliptical 3 or 4 times a week. I do weightlifting. I don't do any running or pounding or anything to pound, but I do stay very active. Much more active than I was on the pain medication. Dr. Sood, as far as I'm concerned, gave me my life back. So I recommend him. I highly recommend Dr. Sood.
Eventually, medication has to get to the receptor in the body where it has to work. Say, for example, a heart medication must get to the heart and work on the receptor in the heart. And since pain is a function of central and peripheral nervous system, a pain medication must get to the spinal cord and specifically to some kind of receptors in the spinal cord for it to work optimally. In certain patients, we find that side effects on the medications become a dose limiting factor when it comes to effectively treating pain in these patients. And we found that if we can effectively deliver the medication directly to the spinal cord, we need to give a minuscule proportion of the dose that we would need to give by mouth. Hence, what we are doing is we are selectively delivering medication to a site where it's exactly needed. Hence, we are bypassing so many other parts of the body where the medication would only be producing side effects.
I've actually had patients come into me and literally, and I've told my wife this when I get home, "Doctor, you've got 3 months to help me. If I don't feel better and you don't help my pain in 3 months, I'm ending it all. I'm of sound mind and body, but I can't go on like this." That's a challenge. It's a situation where there is a lot of pressure because these patients, unfortunately, in many cases have been suffering with chronic pain for years with absolutely no relief. I can't imagine living with that kind of pain. But as you can understand, having visited our facility, it happens all the time. And people are so thankful when you're able to, as I said, give them back their lives. That's who we are. That's what we do.
The story of one of the most unique and highly experienced pain management practices in the country today, Connecticut Pain Care. I'm Doug Llewellyn reporting from Danbury, Connecticut.
Well, that does it for this edition of Close Up on America's Business. I'm Janice Marie. Thanks for joining us. We'll see you next time.